Well, this morning we're enjoying the company of two excellent persons here in Mexico City. The first person that I want to present is Dr. Fagins, James Fagins, and the second person here is Dr. Thomas Robinson. They are huge persons about topics such as obesity here in the United States within other countries. And I want to make some questions. The first is, according with your presentation, the population exclusively is Latin or Hispanic persons, or is involving in the whole country in the United States? In your case, your investigation.
Oh, in our work, it's involving all cultures throughout the United States. Even the lowest risk group, who are Asians, are seeing rapid increases in obesity over time. It's also a problem that's affecting the whole world. Even in very poor, low-income countries and developing countries, you see a rise in obesity at some of the same rates and even a more accelerated rate than we've seen in the United States. They're just starting later. And so this is a problem that is going to be something that the whole world has to face very, very soon. As you know already, in Mexico, you already have a very severe problem with obesity and diabetes. And that's going to manifest itself as a very large economic, social, as well as health problem.
Wow. Thank you so much. Another question I want to make is, how many money spend the government or the programs for detection and treatment of obesity here there in the United States?
Well, that's a tough question. I don't think I know the answer to that, about what the budgets are relating to obesity there. The costs already of treating obesity in adults is already estimated to be more than $150 billion US per year, and probably approaching 200 billion at this point, based on some estimates. That's just the medical costs alone. That doesn't count the costs of absenteeism in the workplace and in school, of reduced productivity, of increased disabilities, as well as a lot of the costs of re-engineering our entire environment. So, as you probably know, as you've seen, you need to have new MRI scanners and new CT scans that will hold very large patients. You need to have new chairs and desks for schools for larger people. Door frames have got to be larger in many places to fit wheelchairs and other things because of people with their osteoarthritis or other bone and joint problems from their obesity. And even the costs of everything we do. The greatest cost in a lot of airlines is fuel costs. And the amount of fuel used in an airplane is strictly related to the weight that you're flying. There's even one airline in Air Samoa, I believe it's called, that actually is the first airline to start charging based on your weight. They put you and your suitcases on a scale, and your ticket cost is based on your weight. So we're going to see many more costs to our society beyond just the health costs. So whether we like it or not, a huge part of our medical care budget for screening, diagnosis, and treatment is going to go towards obesity and its complications.
Oh, thank you. I did make this question because here in Mexico City are working very high in some programs, governmental programs, to treat the obesity here. For example, the EcoBici, the work of traveling here in Mexico City on bicycle. Another program is who is working on is the making some exercise and to get some tickets for transportation. But another question I want to make is, you presented us a picture of an iceberg with two levels, what we're seeing and what we're not, or we cannot see. Here in Mexico, or in a country such as Mexico, which are these parts of the iceberg?
Well, the above the iceberg is sort of the obvious stuff we're seeing on the surface is telling people to eat more healthfully and exercise more to try and reduce the risk of obesity, and trying to get kids to do that, and maybe trying to change some of our environments, some of the obvious stuff. Below the surface of the iceberg are the things that are deeply tied to your culture and to the norms in society, identities, how people like to see themselves, what groups they associate with, how they like the world to see them. So their deeper values in terms of family. You rarely find a parent whose top value isn't the health or the well-being of their child or of their children. So if you can tap into some of those deeper values, some of those sort of cultural values, in Mexican culture, at least to the extent that I'm familiar with, familism and the importance of family is very important. Collectivism and the community is very important. Those things are very important to tap into in anything you do to try and prevent this. Anything you do that contradicts those values or gets in the way of them is going to hit a lot of barriers. So, for example, if you have families where food has been equated with love, and that the way people in the family show their love is by through food, and by particularly high fat, high calorie, high sugar foods, then you have to try and take on that norm, that expectation, so that they learn to show love in more healthful ways. And they need to understand that showing love in a way with high fat, high calorie, high sugary foods is actually harmful to children. We often see families where that's the case, especially in a lot of our Mexican immigrant families, and we work with the children and the parents to talk to their grandparents, for example, or to talk to their parents and say, "I know you love me very much, Grandma, but it would really help me a lot if you would help me by not having all these sweets in the house whenever I come over, by not serving these, because that's going to help me live a healthier life." And so working, actually addressing it up front, and we're not going to change culture and we're not going to change habit overnight. But the problem is, as economies have developed and as you have more access to highly processed packaged foods that tend to be higher in fat and sugar and calories, that we need to change the ways that we operate around food. If we went back to more of our normal historical diets, which were mainly unprocessed fruits and vegetables and grains with some meat but a lot less fat in cooking techniques, a lot less sugar in cooking techniques, then we would be in much better shape.
Thank you. And to finish this interview, I want to make a specific question or a special question, because here in Mexico we have many parents or many family who are in the United States. So the question is, have you seen in your studies difference between the changes, I mean inner changes in the population, American population and Hispanic population? Some kind of diseases which affects a specific group and another it doesn't affect, or is this the common, it's similar in those cases?
I'm not exactly sure. I'm not sure what you're asking, but I think it's certainly a lot of, that Latinos are the largest ethnic group in California right now. There are more Latinos than whites and Europeans in California at this point. And certainly in our patient population, more than 2/3 of our patients are of Mexican origin. So there's other Latino groups too, but mainly Mexican origin. In our research projects, if we work in the lower income groups in particular, sometimes our studies involve 100% Latino populations. Many of those families actually come back and forth between Mexico and the United States. So they'll spend the summer in Mexico. They'll come back during the school year to the United States. We have members of the family that come back and forth too. So there's a lot of commonality between what's going on in Mexico here. Now, I know that our Mexican immigrants in the United States are not representative of the entire Mexican population. They're a subgroup that decided to emigrate for economic or family reasons and stuff. But certainly, I think there's a lot of common cultural things. What we're finding, which is really interesting, is the children growing up often, not all the time, but often don't even speak Spanish. They go to school in the United States and they learn English, and we may have households where the children speak English and the parents speak Spanish. So for all of our programs, most of our programs, when we work with the parents, we do everything in Spanish. When we work with the children, we're doing things in English. So there's a big cultural divide between the children and the parents. I described one of our programs which involves ballet folklorico classes, and at least for girls, as I explained too, that in the United States it's tougher to get boys to dance, whereas I know in Mexico boys participate in folkloric dance. But that's something that both the kids enjoy because it's fun. They love the costumes, they love the music, they love the choreography, they love learning about the different dances from the different states of Mexico and the different regions. All the different costumes are different, as you know, from each different region. And their parents also love it because the kids are then learning something about what the parents grew up with when they were growing up in Mexico too. That's one of those things that goes beneath the surface of the iceberg. It's one of the things that's below. It's hitting it a cultural value in something, and so we're addressing that for both the parents and the kids. I think that's very important. We do find in response to those programs that the kids then become more Mexican. They become more, they start to identify more as Mexican, which I think is also good, and it's brought families together in some way. But at the same time, we see other complications, like I was talking about before. I have patients who've lost a tremendous amount of weight on their own, teenagers in particular, who decided they were going to take matters under their own control, and to take control of their lives, and they started exercising and changing their diet. And I have their parents, and I have one patient who lost 70 pounds over a year and a half just through diet and physical activity. Pretty amazing. It's rare. We rarely see that, almost never see that. But he was able to do it and then maintain a normal weight for the next 7 or 8 years. He's now in college. He was 14 when I first saw him. And actually he's applying to medical school. But his parents would come in to me and say, I think he's too thin. I think he's losing weight. Yet everybody in the family had diabetes and was overweight, but to them, he was too thin. So we're dealing with a lot of things, and I think you're going to see, or you already are seeing, similar probably complications in Mexico with families as obesity has become more prevalent, and as resources, are not really there. Now, one thing that you've been more effective at in Mexico than we have been is, for example, the new taxes on sugar drinks and junk food, and on junk food. The new taxes are something that we've been trying to get through in the United States for a long time. We're yet to have that succeed in any place. Now you have a national excise tax, I believe, it's on sugary drinks, and that's tremendous. Not because I believe that we need to add taxes to overweight people to penalize them, because there's some people who argue that, but it's because that's the real cost of those foods. In fact, the taxes should be much, much higher. Just like with tobacco, the real cost of junk food, the real cost of sugary drinks to society is much, much higher than the cost you pay than what's a Coke now, 70 pesos, 100 pesos, whatever. But it's 100 pesos, that the actual cost of that soft drink is much, much higher because you're paying for it in the cost of medical care and societal costs for treating the diabetes later. So by raising the price of foods, it's what economists call externalities. By raising those prices to the actual cost, you're actually creating a real free market that doesn't exist now, because those costs are being borne by us as a society not by the consumers who are buying those products.
Thank you so much. I just want to make a question because this is so interesting. This is so, and it's a huge topic we are talking. Another question what I want to make is, which are the difference between the intellectual levels in the persons with obesity in the studies that you have public? Because you mentioned something about the changes in intellectual, but which are the levels of IQ in persons with obesity and persons with a healthy with a health?
Well, that's an interesting question. Actually, there's no difference in IQ that we can measure between obese and non-obese patients. So it's not that people who get obese are less intelligent. However, people who are obese are at greater risk for more complications, more cognitive complications and thinking complications later in life. So they're more likely, if you are obese and as you grow older, you're going to have a higher risk for memory problems, higher risk for the types of problems you see with Alzheimer's disease and things like that. So it is an impact, the amount of fat in the body and probably the diabetes and other factors are weighing are adding to your risk of future cognitive problems. But it's not that you start out with less IQ, and that's what makes you obese. I want to make sure people understand that. So obese people are not less intelligent than non-obese people.
Yes, I make that question because I don't know exactly, but in some American cartoons or movies, we can see the persons who are expert in the computer is a huge person. Is a novice person. So I did make that question because how can be difference between an intellectual and a person with obesity and a thin person?
Well, we all live in a very toxic environment where food is cheap and plentiful and tastes really good, and everywhere you turn, there's a fast food restaurant or a food cart or somebody on every corner, and in addition, we've managed to engineer physical activity out of our lives. Kids don't walk to school anymore in the United States. There's no physical education or very little physical education, at least where they're moving. Most physical education, they're standing still. We don't even walk up flight of stairs. In this building, people are taking the elevator up and down one flight of stairs, one floor. We take escalators and people movers and elevators instead. So we've managed to create a world in which it makes it easier for us to gain weight. It also makes it very, very difficult for parents. We don't want to just blame parents because parents are also the victims here of a society where there's tremendous amount of marketing for food and inactive pursuits, video games and tablets and phones and all those things and computers. So it's basically this environment that we've created has made it very difficult for any of us to maintain weight. Even though the stereotypes may be that obese people are lazy or not self-disciplined, those are just stereotypes. That's not really the case. We don't find any difference. But in fact, because those stereotypes exist, they actually impact obese people to think they are lazier or to think they are less disciplined. And when they believe those same social stereotypes that everybody else does, even though there's no evidence for it, that affects their behavior and makes them less likely to be able to change. We're actually doing some studies now with new techniques to try and address those stereotypes and that stigma, because there's some evidence that if you address social stereotypes and have people focus on things like their core values or on the positive things in their life, they will actually be able to overcome those barriers and make changes more easily than people who are thinking about those stereotypes.
Thank you so much.
Prevenidos, corriendo y grabando. 5, 4, silencio atrás. 3, 2.
Agradecemos la presencia del doctor. Thank you, doctor, for being with us in Mexico City. please tell us more about your specialty. Was the main approach in these days? I'm nervous too, so sorry. Thank you.
4, 3, 2.
Thank you, doctor, for being with us. I wanted to ask you for the new approaches you're gonna extend to us tomorrow against cancer, thyroid cancer. So if you can tell us more about it, the new approaches, the new techniques you're going to expose.
Sure. So I work at a cancer hospital at Memorial Sloan Kettering in New York, and my particular interest is trying to understand the biology of thyroid cancers, the particular genetic mechanisms that lead cancers to develop initially and ultimately to progress and to metastasize. And as you probably know, the approach to treatment to cancer in general is being revolutionized by our deeper understanding of the genetic basis of the disease. That's happening across many tumor types. And it's very much the case as well for the thyroid. And it's important in many respects. I mean, understanding the genetic pathogenesis, first of all, helps us to improve disease prognosis. So patients presenting with thyroid cancer at a particular stage, based on their particular genetic characteristics, may be benefited by some type of therapy, whereas others would not benefit from that treatment. So as you know, also there's been a very, very significant increase worldwide in the incidence of thyroid cancer. And an important cause for this is that we are doing a lot more imaging studies for unrelated reasons. So people, for instance, more frequently get imaging of the head and the neck, for instance, after a road traffic accident, or if they have a carotid angiogram, if they're being tested for the risk of stroke. And as part of that imaging, incidentally, you image the thyroid gland. And when you do that, very often we find nodules in the thyroid, and that leads to a biopsy, and that in turn leads to often a diagnosis of thyroid cancer that might otherwise have been ignored or not unknown. And what we know is that 6% of the general population have a thyroid cancer. It's very, very common, but only in a very small fraction of those patients, or those individuals, will that thyroid cancer ever develop to anything clinically meaningful. So a big part of this increased incidence of the disease is essentially subclinical disease that probably would be best left alone. So one of the important initiatives that we are taking at our center, and has already been tried in Japan, is to actually convince patients who already have a biopsy-verified diagnosis of thyroid cancer to not have the disease, not have a surgery, and just leave it in place and maintain it under close observation, because in most cases the thyroid cancer will not change over time. Now, in many other patients, the disease is real, the tumors are larger, sometimes they involve lymph nodes in the neck, and there, of course, the treatment is important. And by and large, the first approach to therapy is to do surgery, to remove the thyroid gland, and sometimes the affected lymph nodes as well. And that's often followed by treatment with radioactive iodine. And the reason we use radioactive iodine is because the thyroid cells have this particular property that they can actually incorporate iodine, and that's how they make thyroid hormone. We take advantage of that property to try and give radioactively labeled iodine in high doses that will be specifically trapped by cancer cells, and that can lead to better clinical responses. What we have learned over the past 10 or 15 years is that the effectiveness of this treatment it has not been as good as we thought. And a big approach in my particular lab is to try and enhance the effects of radioactive iodine, and we have been quite successful, at least first in mice and now in patients, to use targeted therapies against the genetic changes in the thyroid cancer to re-engineer or redifferentiate the cell so that they can again trap iodine and respond again to these therapies. So what we're seeing is a new landscape of the disease. We're trying to understand which patients are best left alone, because treatment will be worse than the problem in itself, which patients need limited therapy, and which patients need therapies that can be augmented by specific small molecules that can interfere with the activity of abnormal genes that cause the cancer.
Okay. And this is worldwide. You're speaking worldwide or just regional methods? So.
Well, in terms of the increased incidence, it's worldwide. It happens also it's been seen in Europe, in Japan, in South America. So there's almost a tripling of the frequency of the disease between 1970 and the current time. So that's a huge increase in the number of patients. And as I said, a lot of it is just essentially something that we knew already, but now we know in much greater detail, that it's quite common for people to have small cancers, not only of the thyroid, but also of the prostate, also distal carcinoma in situ of the breast, that many times will never appear to be clinically important. As we do more imaging studies, more CAT scans, more MRIs, more ultrasounds, those small tumors are being discovered, and they therefore hit the registry, the cancer registry, as a real disease. And so that explains as a very significant part of the increase in cancer. Now, of course, there is also an element of a true increase in clinically significant disease. And that we don't quite understand. We know radiation exposure plays a role. So the example that is most famous is after the Chernobyl nuclear reactor accident. There was a very big increase in pediatric thyroid cancers. People are afraid that in Fukushima, where you had the nuclear reactor accident in Japan, there's fears, so far not proven, that there will also be an increase in the disease there. So we know about some environmental factors that could cause an increase in the disease, but we don't know everything that we should know about it. But overall, yes, there's a worldwide increase in the frequency. Now, in terms of how the disease is treated, no, that's still, I would say, at more specialized centers, the approaches are changing very quickly, and they are being translated to the general community at perhaps a slower pace, and that part of our job is to try and help educate and inform people.
Okay. So the recommendations will be to diagnose properly in an earlier stage, so it can be a treatment like more approachable, I don't know.
Well, actually, not really. I mean, we are trying to avoid people, physicians, biopsying very small lesions, because you do not want to diagnose disease that is essentially likely not to grow over time. So it's a change of mentality, right? In the past, we thought we have to pick up the cancer as early as possible. And that's true for many cancers. But in the case of thyroid cancer, the small tumors less than 1 centimeter in size, okay, it's almost better not to know they're there. Okay? In the same way that in older patients with prostate cancer, we don't do the blood test for PSA to find, low level of prostate cancer, because it'll probably never become a problem in their lifetime, say if after the age of 70. So there's a nuance to the issue of early diagnosis. Early diagnosis is good for certain types of tumors where you catch them early. Early diagnosis is a problem when the tumor that you pick up may actually never change over your life course.